palate, O denotes the oropharynx, tongue base and epiglottis were formulated. Then with this we were able to meet anatomical and physiological part. Physiological part by seeing the polysomnography and anatomical part by understanding the anatomy using dyes. Now we were able to get the complete endotype of the patient. Now coming to the treatment part, management part. Initially in 1965 brute force airway bypass was done. That is tracheostomy was done for Pickwickian syndrome, which had human factors, costing the human factors. It achieved the goal of bypassing the obstruction at the upper airway, but it was not physiological. Then later in 1981 the pneumatic revolution came after the invention of CPAP machine by Sullivan. With this we were able to push force airway into the upper airway, which opened the dynamic airway obstruction, and till now this CPAP remains the gold standard treatment of OSA. And parallelly there were other devices like Andrews device, where first mandibular positioning was tried, and these were helping us to move the tongue anteriorly along with the mandible. Then we had tongue retaining devices where mild suction force was used, but it was very uncomfortable to the patient. Now we have mandibular advanced devices where micro titrations can be done, which helps us to get the superior treatment response, and patients adhere to this. Then Stanford made a protocol of maxillary mandibular advancement surgery, where whole maxillary and mandibular was system advanced to create bigger anatomical box. Then maxillary expansion devices also started to evaluate the leading from the pediatric orthodonty, where rapid maxillary expansion devices were used, and in adults Sarpe and Dome and Marpe are used nowadays. This helps in expanding the maxillary box in the transverse manner. Then mandibular stabilization were done by genioglossus advancement and mandibular distraction osteogenesis, where again retroglossal airway was increased. Then the true evolution came with advent of the uvulopalatopharyngoplasty. We came from the era of resection, which was described by Fujita in 1981, where philosophy was more space than through less tissue. So we were traditionally doing in amputation of uvula, trimming of the soft palate and the simple sutures to close. But this demolition work didn't help us completely every time. So then modern era of reconstruction was made through expansion sphincter pharyngoplasty, barbed pharyngoplasty, where tissue prevention over amputation, muscle repositioning, altering of the vectors, altering the mechanical led us to better airway. So from 1981 dissection era we have come to the reconstruction era. Then through barbed wire pharyngoplasties, palatoplasties, we have come to the era of suspension, and in the later we expect AI to help us in predicting more wisely and help in adapting a precision treatment. Then we had other challenges, which was a big breakthrough came in 2012 with advent of hypoglossal nerve stimulation, where because of nerve stimulation retroglossal space was created, and this pacemaker, neuromuscular pacemaker, changed the treatment. Then nowadays we have, apart from surgical treatment, we have pharmacological treatment with advent of GLP and GIP agonist like trizepatide, where we decrease the weight, decrease the fat tissue around the neck. Then we have other drugs, noradrenergic and antimuscarinic combination, which targets the pharyngeal motor effectors, increasing the muscle tone. And now the modern era has evaluated, so our algorithm has changed from evaluation of OSA with patient with suspected OSA CPAP intolerance to prediction of phenotyping, and AI with the advent of AI, we are able to change the mapping of the, we are able to understand the better mapping of the anatomical and physiological targets, and we are able to do targeted multi-level reconstruction. So at present our OSA treatment evolves around personalized precision management because of better understanding of anatomy, physiology, and combination of both with the machine learning. It will help us in getting better care in the future. So era of trial and error medicine has ended. So we are now in the era where we are giving personalized airway reconstruction, and in the future we will be able to do it more better. Beyond anatomical, we have moved beyond the anatomical box to the understanding the biological mastery. In 50 years, OSA treatment has transformed from the blunt force trauma of a tracheotomy to elegant synergy of smart oral appliances, precise maxillofacial remodeling, and AI-driven predictive endotyping. The future of sleep medicine is no longer forcing the airway open, it is mastering the highly individualized structural neurobiology that controls it. So with this I am ending my talk. Thank you. Any questions?
Dr. Tabrez, an excellent presentation.
Thank you, sir. Doctor, thank you for a very illustrative and precise presentation. This presentation has actually emphasized that this is not just a localized disease, it's not just a sleep disordered breathing, but it's a multi-system involvement,
Yes, sir.
which includes cardiovascular, neurodeficits, and neurocognitive problems also there. So you have emphasized everything very clearly. Thank you for once again for the excellent presentation, Doctor.
Thank you, sir.
Thank you, Dr. Mohamed Tabrez, for setting the tone for Thuyilcon 2.0.